So for our next presentation, we have a rock star, and she's going to come up, and it's part of this issue with Naegleria is you can't treat it if you don't know that you have it. So the hardest part is trying to recognize it, and the next person's going to come up, and she's actually recognized it in a case with a positive outcome. So I'd like to welcome up Ms. Shiela Black. She's the coordinator for Florida Hospital.
Thank you so much.
Thanks.
Let's see if I can operate this. I can operate a multi-million-dollar piece of equipment, but I don't know about a pointer. So I'm thrilled to be here today. I almost feel like this is a reunion. This is my third visit to the summit, and we're growing in numbers every year. So I want to take you on a journey that we've been on in the clinical laboratory and share with you the story and the information that we've been able to share from the laboratory perspective. And I know even last year, Dr. Gumpf had mentioned, is there anybody out there that can help my laboratory? They need help. And that's what we want to do, is share the information that we have learned and we've put together. So that's what I want to share with you today. So the first thing that I want to share, basically the whole presentation is something that we did back in April in the medical ground rounds here at Florida Hospital. And that was geared toward an audience of all healthcare professionals, but specifically medical technologists, and that's what this talk is for, really. And I wanted to share with them the distribution. This was the actual CDC map from 2015. And we know the cases have gone up to, since we had 5 cases last year. And we know that Florida, Texas, and Louisiana are the only states currently that are required to report this to state agencies. But the critical point about showing the map to people who are diagnosing this is it can happen anywhere. In Sebastian's case last year, Sebastian lives in South Florida. The reason I was able to be part of that case is he went on vacation and he ended up here in Central Florida. Sebastian and his family could have gone anywhere. Anywhere in the United States, outside of the country. He could have ended up in the state of Washington. And we need to know that this can happen and be diagnosed anywhere, regardless of where these people are getting infected. And my peer, Maria Brock, who's the hematology laboratory manager here at Florida Hospital, she gives talks all over the country for American Society for Clinical Pathology. And she's had several people come up to her and say, how can we get this information? We don't get this information where we live. So there are people that want the information, and that's what we're trying to reach, that audience. So I want to introduce you to my team. Sometimes it's difficult to keep them on their toes, so you have to do various things. So these are an amazing group of people, and we are kind of unique in that we have a weekend team. We're here every weekend. Some of us do 32 hours, and that's how I happened to be there on the weekend that Sebastian came into our emergency room. And again, this was first presented back in the medical grand rounds in April. April is the month that we celebrate Medical Laboratory Week and recognizing all of those healthcare professionals who are the heroes behind the scenes. So all of my laboratory professional friends that are here today, thank you for being here. And this is for you. So being a medical technologist, our background a little bit is that we are all detectives, and like most healthcare professionals, we are trying to find the answer. So these are some of the shows that are some of my favorites, and my goal is to always try to figure out the answer before they get to the end of the story so I can say that I knew that's what that was. And interestingly enough, like I'd like to share with them, is that this show Monsters Inside Me had actually one of our family's stories featured on that, so that really brings it home as well. So I share with them about the summit and what the purpose of it was and how this all started and literally how this affected me. I had no idea anything about Jordan's case. I didn't. But when I found out that we were going to have an all-day seminar about the brain-eating amoeba, I wanted to learn more. This is something that we learn when we're in school, but you literally spend 10 minutes on it. It's not out until you get into the real world and you see cases like this that you learn. You learn from your peers and you teach others. So several of us were really excited to come, and we did. So I share with them what the purpose of these summits are. and how we brought together professionals to learn from each other and about these cases. And I have to tell you that nothing spoke more volumes to me than listening to the stories of each of those families that came to that very first summit and talked about the loved ones that they had lost. And that's really what stayed with me. I tell them about the research that's going on, about actually looking for the number of PAM cases that are actually happening. And I have to tell you, when I was doing some research, I read about a retrospective study that was done, and I believe it was in Virginia, where they looked at 16,000 cases where people had died from meningitis, and they went back and looked at those cases, and some of them were actually amoeba cases. And this, I think the study went back as far as 1934. So interesting, do we actually have the true number of cases that are happening? And we're changing care pathways because of what's happening here, and that's really exciting. And finally, I like to tell them about the research and to find treatment about what's going on. So after that first summit, we had no idea how emotional that day was gonna be. We had no idea how inspired we were gonna come away from, and most importantly, I had no idea how involved I was gonna become in this. So we went back to our lab and we wanted to know, what can we do better? How can we prevent cases like Jordan's and other children? And we started asking questions of ourselves of what processes can we change, how can we improve? We started to become advocates. We wanted to work with the Children's Hospital. We wanted to make people aware. We wanted to know what we could do. And we started to emphasize best practices. So that was after the first summit. And then a Sunday afternoon happened in August of 2016. I have to tell you, in healthcare, most of you know that things happen after hours. They happen on a full moon. They happen when somebody goes to lunch, and they happen on the weekend. On a Sunday afternoon, being a lab coordinator, my job is to fill in where there are holes. So when somebody goes to lunch, I fill in. And I came out of my office cubicle and I saw spinal fluid from the emergency room that needed to be counted. Now, obviously, anything from the emergency room we want to expedite, so I sat down to count. And because somebody had gone to lunch. So when I sat down to do that spinal fluid, it wasn't very difficult. I can tell you exactly the number of cells. There were 10 red cells and approximately 100 white cells. Certainly not normal, but nothing grossly abnormal to alarm me. And I went to write down my numbers. And when I went to write those numbers on the requisition, I saw that this was a 16-year-old male in the emergency room with a headache. And something clicked in. The Amoeba Summit kicked in, and the information that I was given that heightened my awareness and renewed my awareness. This is something I'd always known about, but not something I always think about. And because of that awareness, I went back. The first chamber that I focused on, I saw an organism that I thought was moving. Now, sometimes your imagination gets the best of you, and you think things are moving when they're not. So I called two of my peers that were in the room with me, and I said, you need to check this and make sure this is moving. And before they even sat down, I was on the phone with Dr. Hernandez in the emergency room. Another thing clicked in. I said to Dr. Hernandez, I think we have an amoeba. Has there been water exposure? I've never asked that question before, but it's because of this summit that I did. And they had to go back to Sebastian's family and asked, because it wasn't even a forethought in the emergency room at that time, that this could have possibly been an amoeba case. And needless to say, the rest is history. Last year, this made headlines and was an amazing case to be part of. And the most amazing thing was to see Sebastian and his mom Skyped into this meeting last year to where we could see them and see that he's doing well. And Sebastian's mother said it better than anything. She said that her son is alive because of your son. So that's just amazing. And then the second Amoeba Summit happened just after that, and 3 teams were created: the awareness, the early detection, and the research. I became very involved in the awareness portion thanks to Maria Brock, my peer, who roped me into that, and I'm so glad she did. So this is what came out of that and what our work that we did together. Through the Florida Hospital Innovation Lab, I don't know if you're aware of this or ever had the opportunity to go there. This is a place inside Florida Hospital where there are no walls, there are no barriers, there are no titles. This is where people come to brainstorm and solve problems. And Maria thought it would be a great idea if we brought together people who could give us some ideas about what to do about increasing awareness. And whenever you come to the Innovation Lab, you have to name your team. So we became the Amoeba Slayers. Maria sent out 27 different invitations that day, and five very passionate people showed up. We had myself and Maria from Florida Hospital, Mark Lamusco from Florida Hospital East, Maria Rodriguez from Osceola, and last but not least, Mr. Jack Tracy from the Department of Health, who has kept us all on track and in line. And we had to come up with an idea of what we wanted to do, and this was our ideas, like how can we increase the awareness of amoeba to med techs? The laboratory is what we knew, so that's where we wanted to start, and that's what we started working on. So we started to write best practices down, and that's what I want to share with you over the next few minutes. There's some best practices for any clinical laboratory. This can happen in any clinical laboratory 24 hours a day, 7 days a week. The tools are there. What's needed is the awareness and the education and the effort to be put into it to make everyone aware of it, and that's what we want to do. So one of the first things I realized after I went to the first summit, I came back to our laboratory, is we didn't have an order for the physician to ask us to look for amoeba. It's kind of strange. We have so many orders for everything else. If we saw amoeba in previous cases over the years, we would include it as a comment in the body fluid report. But again, that is so critical for that communication piece to get to the laboratory, because this isn't something that everybody is going to know to take the extra time to look for. So having a standard order does two things. It alerts the laboratory, and it also allows for standard reporting. So when we report in the laboratory, this automatically goes to the state, as Florida is a state that's required to report this to the state. What we also didn't know at the same time is that care pathways were being changed in the background. And what this did for us was when a patient comes to the emergency room and they present with symptoms of meningitis, the physician is now prompted to ask the question, has there been water exposure? We've never had that before. So even though, yes, and that's come out of this workway. So what that does for us in the laboratory, this is now part of our cell count, which is a general order that we do on all spinal fluids, quite honestly, in addition to glucose, protein, and cell cultures, we do a cell count. And that's usually where the amoeba are found, is in a wet prep. So when we go to enter our results for that cell count, we can see the answer to that question, has there been water exposure, yes or no? Up until recently, it hasn't been mandatory, but it is now mandatory for all pediatric cases for that question to be answered. And you know what? Even if it's not answered, the technologist is still seeing the prompt. And it's a clue for us that this still may be up to us to make the diagnosis. So it's been invaluable. So one of the other things you need to look at when in your own laboratory when you're talking about this is looking at addressing these with urgency. We know that cells start to lyse within 30 minutes of the sample being taken from the patient. So you want to make sure that you're addressing any sample that's delivered to the lab as soon as possible. So for us, the emergency room used to be literally right below us. It is now clear on the other side of the hospital. We have a pneumatic tube system, but I have to tell you, things happen with pneumatic tube systems. So any fluid such as a spinal fluid or body fluid that cannot be easily recollected, we request that that is hand delivered to the laboratory. So that's getting it to the lab. You also have to look at processes of how to handle it once it's in your laboratory. You have to educate not only the med techs, but you have to educate the specimen processors who are getting that sample delivered to them and letting them know the urgency of this. Depending on the amount of sample size that you get, we may have to share amongst departments between micro, chemistry, and hematology. It's critical for microbiology that cell cultures are kept sterile, so they are usually the first ones to obtain the sample, and then it gets to hematology where we're doing our wet prep. Some other things we considered was looking at avoiding the use of the automation of cell counters. Automation is wonderful, but sometimes you just can't beat the old ways. And this is one particular case. Most cases have been detected when we're doing the cell count in hematology, and automation does not allow for that. When you use an automated cell counter, you can't see movement, and that's the gold standard for looking at amoeba, is the movement under the microscope. And so what we're recommending for people or laboratories that use automation is to back this up with a wet prep in addition to doing your cell count. And this should be done routinely. We're also talking about using the avoidance of avoiding contrast stains. For doing a wet prep and a cell count, sometimes it's hard to distinguish between red cells and white cells on a counting chamber. So many techs will use a contrast stain, and the white cells will pick that up, and the white cells stain purple. So it's very easy to do your manual count that way. But we also know about these contrast stains is that it can immobilize, if not kill, the amoeba. So we highly recommend that that is not used when doing a cell count on these spinal fluid samples that are potentially containing amoeba. And some other ways to enhance amoeba recovery include the following. Mixing the sample thoroughly before plating. That sounds simple, right? But these amoeba have a tendency to adhere to the sides of these tubes that we receive the spinal fluid in, so it's very critical to even flick the side of the tube, or if not, gently vortex to dislodge those amoeba. We also talk about warming an aliquot of the sample or the slide before plating. These are thermophilic organisms. They love warmth, and in order to get them to move, which is again the gold standard under the microscope, you want to try to entice them to move. So a way to do that is warming a sample of the sample. You can use a water bath or an incubator. And something we had taught to our techs was that if you played it on a slide and you kept it under the microscope for a few moments, the simple warming of the light bulb under the microscope could be enough to enhance that movement. Well, we were recently blessed with 2 brand new microscopes. Guess what microscopes are created with these days? LED lights. LED lights do not get warm. So we had to go back and re-educate our staff that this is not necessarily a way to do this. So we have to take extra measures to warm those samples. Something we had talked about, I guess just last year, was mixing the sample with some water. And I think we had talked with Dr. Cabral maybe at one point and kind of discussed that. But I think that's more left for research because we talked about inflagellation. It may or may not occur, and if it does, it could take up to 24 hours. So not necessarily something you'd want to use in your clinical laboratory to expedite diagnosis or finding them. And then also concentrating an aliquot by spinning in a centrifuge. Every laboratory has a centrifuge. Spinning for approximately 2,000 RPMs for 5 minutes is enough to do that. And then taking the pellet out and putting that under the microscope. And then importantly, not refrigerating or freezing the CF sample if we want to follow it with testing by the CDC with PCR. Oops, went too far. So, Chad, this is one video that I'd like to show the movement, if you could help me. Now, this is actually a patient sample that we've had in our laboratory, and this shows the forward progressive movement of the amoeba. And I have to tell you, if you were going really fast, like some of us do, you could miss this. If you're not watching for the amoeba, and this guy's moving fast, you'll see him move from one chamber to the next. You'll see the pseudopods. And it's really, when you see it, it kind of takes your breath away because you know what's to come. So my point is here, you can see the lack of cellular material in the grid there, and that's actually a hemocytology chamber that we use to count red cells and white cells on body fluids, including spinal fluids. And this is actually from a spinal fluid sample from a patient. If you were going too fast, we get debris and fluids, whether it's a lining cell or just what we call garbage or macrophages. If you were going too fast, you could miss this very easily. So I wanted to show you this, and what we're also trying to do in our laboratory and to make available to others is creating a library of things like this. This isn't something that you see every day, but when you do see it, it's critical. So I thought this was really important to show you. This does take a few more minutes. He's going to make his way over to the other side of the chamber, but it's fascinating to watch. They don't all look like this, and again, this guy's moving pretty fast, and a lot of times all you're going to see is the pseudopods moving, but you can see he has progressed from one side of the chamber to the other. Okay, and I've got, I'm going to go to the next one, Chad. This is another patient sample that was plated, and I want you to notice how subtle the movement is of this amoeba. Again, if I was going fast, I could easily miss this. So if the laboratory is not informed that this is a potential for the patient in the emergency room, it could easily be missed. So again, communication is critical, education is critical, and awareness is critical. And I have to tell you, when we get a spinal fluid to the laboratory, we do a macroscopic examination for color and clarity. A lot of times we'll get what we call hot fluids, so we know there's red cells and white cells in there, possibly bacteria or something else in a typical case of meningitis. Sebastian's spinal fluid was colorless and clear, 10 red cells and 100 white cells. Nothing very alarming. But this is what we saw in Sebastian's spinal fluid. Okay. One of the other things we're recommending is that a cytospin stain smear be prepared on every spinal fluid sample. And up until recently, we weren't doing that. If the cell count was less than 5 WBCs, we did not require a cytospin to be prepared or a differential to be performed. We have changed that. We're now recommending that a cytospin be prepared on all spinal fluid samples regardless of the cell count. We're also recommending that a right stain be utilized, and I'll show you why in a moment, because a lot of people think about gram stain back in microbiology. This is a right Giemsa stain from hematology. The one slide is courtesy of the CDC, the trophozoite, and the other ones are actually patient samples. And again, I'm not technical because I'm not going to use the pointer, but there's some red cells, some lymphocytes, some segmented neutrophils, and those ubiquitous organisms next to those cells are the amoeba. You can see they're vacuolated. You can see the nucleus. And if this was for a trained technologist, not even that easy to pick up. And if you had somebody who was sitting down to do this and read this, they might mistake that for a macrophage, an epithelial cell, or a lining cell, and certainly not amoeba. So again, education is critical. And again, we're trying to create a library with those videos and these types of photomicrographs and slides, real-time slides or real-life slides that we can use to educate staff. This is a gram stain. I don't know about you, but those look like macrophages to me. Those are actually amoeba. There's really no definitive way in a gram stain to tell that these are actually organisms. And we know that gram stains actually, the process itself, you have to use heat fixation to fix the specimen to the slide, and that destroys the morphology of the organism. Something that we have recently changed and what we're working on is creating a whole new order for amoeba in our laboratory. And the wet prep is going to be going to microbiology, and they're going to be doing a trichrome stain. And hematology will still be doing their cell count as well as the right stain. So we've got more eyes looking on these samples. And I have to tell you, in the last few months, the awareness has been so heightened. We've had some cases where we thought they were amoeba and they truly weren't. We're seeing things that we've never seen before because of the heightened awareness. And it's very difficult to describe it when you don't want to tell the physician because you're not sure. I know Dr. Ali helped us on the July 4th weekend try to determine whether we had a case. But what we're seeing is something called chemotaxis, which is actually the cells, they're phagocytizing other things, or they're actually lysing. And it was like, why have we never seen this before? It's because we haven't looked. We haven't studied it as hard as we have now. So the awareness is out there, and it's growing. And I'd rather have a false positive than a false negative. So we also need to notify the physician immediately. Patient's physician should be notified without delay. And again, your pathologist needs to be consulted so they can come in and do a confirmation. And finally, we want to send to the CDC to confirm with them through PCR testing to make sure that you're actually dealing with amoeba. So what's next? This is the exciting part for our team, the Amoeba Slayers. We wanted to create an educational video so we could share this information not just here, but through the state, through the United States, and maybe go global, who knows. Everybody needs continuing education, and we wanted to create this video to provide continuing education for people, to give you your mandatory credits that you need, but also to give you an insight to this critical topic that is over 97% fatal and 100% preventable. So we've been writing scripts, we've been filming, and it's been an exciting time for us. And I have to share with you, in the process of creating this video, we got Dr. Cope to work with us, and the Smelskis, and so many incredible people. And we thought it would be great if we were able to get the medical technologist that was involved in the Kaylee Harding case, who was only the third survivor before Sebastian's case. And the med tech that was there, her name was Francine Johns. She goes by Frankie. And I had the opportunity to speak with her. Jack Tracy and I did on the phone, and asked her about her experience. Frankie happened to be in the laboratory that night doing competencies for her staff, and somebody went to dinner. I told you when things happen, right? She sat down to look, and sure enough, there was an amoeba. And she said that case affected her so much. She was supposed to retire that year. She said she couldn't retire. She had to stay, she had to educate, and she had to train the newer techs that were coming in. She was that dedicated to this, and it wasn't until just this past spring that she decided to retire. So we've included her in this video. So the point is, this has to be on everyone's radar, and that's what we're trying to do. And I recently, or back in the spring, listened to Dr. Sharon do a presentation he did with emergency medical physicians here in Central Florida, and he said something that I have here: a diagnosis not thought of is a diagnosis not made. And that is so very true. If we're not thinking about it, we can so easily miss it. So I'll leave you with that. And Chad has actually a 35-second video clip of our educational video. I've not seen it, so I'm kind of excited to see that with you.
The Jordan Smelski Foundation is dedicated to global education of Naegleria fowleri and PAM. As part of that goal, they have funded a continued education course that will be sent to medical professionals around the world that will educate on lab detection techniques and treatment. It will also cover 3 case studies. Request this educational course for your medical facility today, and together we can eliminate fatalities from Naegleria fowleri.
So thank you. If there's any questions, I'll be more than happy to try to answer them. And if not, I'll turn it back to Mr. Smelski. Oh, hey, Dr. Lee.
Oh, this was a very great presentation. Thank you.
Thank you.
I just have one comment. So you mentioned that at CDC we do not accept, or it's like not a good specimen, CSF, if it is like refrigerated or frozen. But actually we do accept refrigerated or specimen that was frozen for PCR, because that will not affect PCR. That will affect the culture. But we can still accept.
Good to know. Thank you.
Yeah. So this is something I wanted to clarify. Yeah, thanks.
valuable information really is when we have suspect cases or real cases, we debrief. Therefore, we always collaborate with Children's Hospital, with the Children's Hospital. Susan, thank you very much. We also talk to the infectious disease. We talk to anyone and everyone, and that's how we debrief. The other thing I wanted to share with you, if you know of anyone who's really interested, we are into knowledge exchange. Therefore, if anybody outside of Florida Hospital would like our procedures or any knowledge that they needed, please feel free. Contact Sheila or myself, Maria Brock, and we would gladly share our SOPs with them. Thank you.
Thank you.